Okay, it looks like things have stabilized out.
Okay, we could start.
All right, so
I guess David can do the Q&A part at the end. He just joined
yeah,
us.
that would be great. Okay, hi everyone. My name's Amit Persad. I'm a fellow with Dr. Stephen Chang, who generally leads this, and he invited me to give a talk to you guys on trigeminal neuralgia. So I'm a Canadian trained neurosurgeon. I finished my neurosurgical training last year and have continued on my education with Dr. Chang, who's an expert in many different facets of neurosurgery, but in particular oncology and radiosurgery. But he has one of the largest practices of trigeminal neuralgia in the United States, and so he takes a special interest in this condition. And I as well have a lot of interest in this condition and have done some previous research on the topic. So the topic of the talk today is going to be specifically about surgery for trigeminal neuralgia or procedural treatment of trigeminal neuralgia. Just providing a high-level summary of the different topics in treatment of trigeminal neuralgia with some insights into how we make decisions for all of your guys' benefits. And we'll do some questions at the end and leave some good time for that. So in this talk, we'll talk a little bit about trigeminal neuralgia. Most of you guys, or maybe all of you guys, know what this is in some detail and maybe have firsthand experience with it. We'll talk about when surgery is needed for trigeminal neuralgia, and we'll talk about what procedures are available and how well the different procedures work. So trigeminal neuralgia is one of the worst pains experienced by human beings. It's a debilitating type of pain that goes down the branches of the trigeminal nerve. The old-fashioned name for it is tic douloureux, which is a French terminology that means the painful tick. It was first described in 1773, and then in 1829, Dr. Bell described the role of the trigeminal nerve in trigeminal neuralgia and hypothesized that the nerve dysfunction was related to pain. In 1934, Dr. Walter Dandy, who's one of the founding fathers of neurosurgery, noticed that in most of the patients he was treating for this condition, there was a blood vessel that was touching the nerve. And in 1967, Peter Ginetta, who he described the technique for the modern MVD, and he really was one of the people who built the field of surgical treatment of trigeminal neuralgia. The illustration is by Dr. Harvey Cushing, which any discussion of neurosurgery would be incomplete without a mention of Dr. Cushing, who is sort of our founding father in the field of neurosurgery. He drew very detailed drawings of many of his procedures, including his approach to treating trigeminal neuralgia. Seen here, it's a different approach than we take now, but is the trigeminal nerve at its ganglion where the nerve splits into three. So here's a snapshot of a couple of the diagnostic criteria of trigeminal neuralgia. I'm not going to go through all of it, but long story short, it's a pain that follows the trigeminal nerve distribution, and it comes in episodes, lasting either just a tick or a couple of minutes. And it's shock-like shooting or stabbing pain that's triggered often by stimuli like brushing the teeth or drinking water. And there isn't a neurological deficit along with it. So, as I said, it's typically described as stabbing, shock-like, electrical, or lancinating. It's very bad, and it's exacerbated by touching the affected areas, things like shaving, chewing, drinking water, or even just a breeze of air. And just a quick note, this is a very frequent topic of discussion. Sometimes there's constant pain without triggers, or burning pain, or facial numbness with pain. This is not usually typical trigeminal neuralgia. It's usually neuropathic facial pain. It can be a complicated type of trigeminal neuralgia. The problem is that this type of pain responds much less well to surgery, or at least the conventional surgical approaches. And so it requires a little bit of extra thought and expertise. Why does trigeminal neuralgia happen? Well, the answer to that's pretty complicated, but at a high level, there's this picture on the side where it shows the nerve with either arteries, the red vessels or arteries, or veins with the blue vessels or veins touching the trigeminal nerve. And it's thought that the pumping of the arteries and the pressure from the veins cause irritation in the nerve, which over time cause a process called demyelination, which comes from inflammation of nerve tissue, which is where the lining of the nerve, think of it like a wire. The nerve has like an electrical segment to it on the inside of it, but it's got this insulating thing around it called myelin. And if you demyelinate, it's like exposing parts of a wire. So it's going to start acting weird. It's going to stop conducting as fast, and it's going to start shooting sparks out, just like a wire would if it's stripped. It becomes a little bit dangerous. So the same sort of thing happens in trigeminal neuralgia, and that's thought to result in pain and maybe inflammation over time. There's other things that can lead to trigeminal neuralgia. We're not going to touch on them much in this talk. Multiple sclerosis, which is very common where I trained in Canada. It can cause trigeminal neuralgia more rarely. And brain tumors in the region that press on the nerve can also cause trigeminal neuralgia. And another common question is, does it happen alone? There's some people who come into the clinic and they've got bad facial pain along one part of the trigeminal nerve, but they also have deep ear pain or pain in the back of their throat, or their face is twitching. So there's a whole host of other conditions called hemifacial spasm, which is where the facial nerve, which is right below the trigeminal nerve, is touched by a blood vessel, or glossopharyngeal neuralgia, which is where the glossopharyngeal nerve, which is responsible for sensation in the back of the throat, is touched by a blood vessel, or geniculate neuralgia, which supplies the deep part of the ear, and that can be touched by a vessel, or HELP syndrome, which is very new and very rare, which results in sort of a spasming in the back of the throat from touching the vagus nerve, which is responsible for that part of the motor control of the muscles of the throat. So, I mean, it's a lot to take in, but basically trigeminal neuralgia can come in all shapes and sizes, and it can come together with other conditions as well. It's never something to write off just because there's a little bit of pain that you wouldn't expect. It can be from a different nerve being involved as well. The treatment's usually medical, in the first, at least in the first stage. So carbamazepine is the conventional, traditional medication that was treated with. Now there's newer drugs like oxcarbazepine. There's other nerve targeting drugs like gabapentin and pregabalin. And then if and when that doesn't work, surgery in its various forms is an option for treatment. When do you get surgery? So you'll hear a variety of different indications for surgery from a variety of different people. If the medications aren't controlling the pain, then that can be an indication for surgery. If the medications have too many side effects and you can't tolerate it, that can be an indication for surgery. If you just prefer a surgical treatment, that can be an indication for surgery as well. Maybe you're tolerating the medication, but you don't want to take them. But the critical thing is, the best thing to indicate a surgery is that the MRI shows a vessel touching the nerve. If there's a vessel touching the nerve, which we'll get into in a second, it's much more high utility to do a surgery to peel that vessel off. And very frequently that results in a lot of relief. So now getting into the surgery, what kinds of surgery are there? There's more than this. I'll talk a little bit about a fourth option and a fifth option at the end. I don't have much about it in the talk itself. There are newer things that are developing, but traditionally, there's three different things you can do for trigeminal neuralgia. There's microvascular decompression, which is open surgery that I was alluding to before, that Dr. Peter Janetta invented. There's rhizotomy, which is really just a technical term that means cause some sort of damage to a nerve. And it comes in three main flavors. And there's stereotactic radiosurgery, which is a non-invasive way of doing a rhizotomy, essentially. It causes damage to a nerve, but it doesn't require any sort of anesthetic or damage to any of your tissues. So microvascular decompression, it's open surgery. It requires a general anesthetic. You have to get a breathing tube in and go to sleep in order for the surgery to happen. The goal is to peel a blood vessel off a nerve if we find it on the MRI in order to stop the irritation. And it does really well at controlling pain. It's best to do if there's a blood vessel seen on MRI pressing the nerve, but sometimes there isn't a blood vessel seen on MRI and there can be a blood vessel inside of the surgery. That's a bit of a gamble. It doesn't always result in finding a blood vessel if you don't see one on the MRI, but if the pain is bad enough and you have trigeminal neuralgia that behaves like normal trigeminal neuralgia, sometimes it's worth a surgical look. So what I keep mentioning, a blood vessel touching a nerve on MRI. This is a picture of an MRI. This is a sequence called the T2. You can tell because the fluid that bathes the brain, called cerebrospinal fluid, lights up bright white. This is the brain itself. This is the brain stem. These are the sinuses behind the nose. This bright stuff is the skin and the underlying fatty tissue from the skin. And back here is a cut through the brain stem and the bottom part of the brain. So these are your temporal lobes, occipital lobes. The picture is flipped as if we're looking up at you from your feet looking upwards, and so the left side of the screen is the right side of the head. And on the left side over here, so the right side of the screen, left side of the actual brain, this is the trigeminal nerve, this bracket-shaped sheath that goes forward. You can see the same thing on the other side. But unlike on the other side, there's a smaller little structure here that is a loop of blood vessel that's touching the nerve and potentially leading to the symptoms in this particular patient. There's a couple of other hints that go along with trigeminal neuralgia on this slice of MRI. The most prominent of which is that this isn't a perfect cut of this nerve, but if you look at this nerve, it's pretty even in width along its whole length. Sure, it gets a little bit wider as it goes out, but it's not super wasted at the bottom. This one, it's much thinner at the brainstem than it is as it goes out towards the main part of the nerve. That sort of kinking of the nerve can happen from the blood vessel pushing it over time. So then what do we do for an MVD? So as I said, it's an open surgery. So it comes with a little bit of shaving of the hair just behind the ear. And we plan for an incision behind the ear in order to essentially do this. We find the trigeminal nerve, find the arteries that are bothering it, and surround it with a sponge or use some sort of method to take the arteries off of the nerve. So this is a picture from online, the Neurosurgical Atlas. So this is a picture of our surgery. So there's been a cut made. These are the major veins at the head. So the transverse sinus and the sigmoid sinus, the transverse and sigmoid. And then this is a craniotomy, which is just a technical term that means taking off a piece of bone made by making a hole at the intersection between these two sinuses and using this device called a craniotome to carve a piece of bone out so that we can get down to the dura underneath. And once we get down to the dura, which is the thick leathery lining around the brain, we open up the dura and then use some dissection to get around the cerebellum, which is the bulkiest part of the back of the brain that's pictured over here. I'm just going to check. Is my mouse actually visible?
What was that again?
Is my mouse pointer actually visible? I've been using it.
Yes.
Okay, perfect. So yeah, the cerebellum is being pulled back. This is the base of the skull with the dura, that leathery thick lining of the brain over top of it. And we slip around the edge of the cerebellum to find a nice view of the nerve. The trigeminal nerve is pictured here. Right below it is the facial nerve, like I mentioned before. And over here, you can see there's this artery that's pushing up against the trigeminal nerve. It's held in place by this arachnoid, which is a web-like layer underneath the dura that runs over top all of the brain. And by cutting the arachnoid, separating the vessel, we can then slip a Teflon pad, like I mentioned earlier, in between the vessel and the nerve in order to relieve the pain. Here's a video of that procedure. So this is a surgical procedure. I'm going to pause as we're going to sort of explain. So this is a dissection taking place. Underneath there, that flash of white is the nerve. The cerebellum is underneath this very bright white thing, which is a cotton patty. And all of this web-like stuff is arachnoid. You can see there's a red blood vessel over there that is probably causing the trigeminal neuralgia. So we cut away the web-like arachnoid over top of the nerve, and we use that to free the blood vessel so that we can move it around. We then put in a couple of different implements to retract the brain. This now shiny substance is a metal retractor that's holding the cerebellum back. And again, this shiny white is the nerve, and you can see the blood vessel there. So we continue to dissect the blood vessel away from the nerve so it isn't touching it at all, using the scissor to cut the arachnoid and free the blood vessel. And then we flip the blood vessel away from the nerve to make sure that it's no longer touching the nerve. There's still a little bit of adherence there, so we cut that adhesion. And then, as I mentioned, there's a lot of different ways to skin the cat. You can use Teflon pads, you can use glue. At the center I was at, when I did this procedure, we were using glue. So we used some tissue glue to hold the nerve in place up against the bone, away from the nerve. And then we make sure that the nerve is okay. This is a stimulating probe to monitor the nerve to make sure that everything is functioning okay. We explore around the rest of the nerve, make sure there's no other blood vessels that are maybe causing damage, because it can be more than one blood vessel that's irritating the nerve. And once we're satisfied, we end the procedure. So That being said, how does the microvascular decompression procedure work for trigeminal neuralgia? The answer is it works pretty well. So there's a really good paper from the 90s done by a couple of people. So Dr. Janetta is one of them, who's on that paper. This is published in the New England Journal of Medicine. Dr. Joe is another prominent figure in all sorts of minimally invasive neurosurgery who work in the United States. And there's a couple of more recent reviews and articles that look at more recent results as well. And long story short, 75 to 80%, some say 80 to 90% pain-free at long term. I would say 80 to 90% pain-free at short to intermediate term, and probably more like 3/4 to 80% pain-free at long-term follow-up. The treatment is durable out to about 10 years. Some would say up to even 20 years. But after 10 years, it's about a 1% per year recurrence rate. So if 80% of patients are pain-free at 10 years, at 20 years, it might be more like 70%. All told, though, still pretty good as far as duration and success rates go. You might ask, can it be done again? The answer is yes. There was a recent review in World Neurosurgery that looked at this exact question. They found that around 90% of patients who had a redo procedure for trigeminal neuralgia through the microvascular decompression approach had effective pain control afterwards. However, the duration of the effect was much shorter. After the first procedure, you're looking at, if it works, at least about 10 years of duration of effect. After a second procedure, it's more like 2.5 years. There's also a higher complication rate. And all told, for an open microvascular decompression the first time around, you're probably only looking at about a 5% major complication rate, with about a 5 to 10% minor complication rate, and up to a 20% rate of noticeable numbness afterwards. That's more like 30 to 40% after a second procedure or beyond. So moving on from microvascular decompression, I'll spend a little bit less time with these other ones. Rhizotomy is a less invasive surgery that can be done awake with sedation or under a mild anesthetic with, instead of a breathing tube, a device called a laryngeal mask airway, LMA. And it comes at much less risk for patients who are either frail or elderly or have medical comorbidities that preclude them from having an anesthetic. As I said, it comes in about 3 flavors. Generally speaking, people either use radiofrequency, which uses heat to burn the nerve and cause damage. Remember, as I said, rhizotomy is just a fancy way of saying cause damage to the nerve, because the nerve's working abnormally and causing pain. So if you damage it where it's causing pain, it'll no longer cause the pain. So you either cause the damage with heat, you cause the damage with injecting a chemical to damage the nerve, in this case, glycerol, or you damage the nerve by squeezing it, by inflating a balloon. And you do this by putting a needle through the cheek, aiming towards the foramen ovale, which is the hole in the head through which part of the trigeminal nerve comes out. So you can access the ganglion, which is where all 3 branches of the trigeminal nerve are represented, by coming through that hole in the bottom of the skull. These are, again, some pictures from the Neurosurgical Atlas. So the way this is done, the needle is advanced about an inch away from the corner of the mouth, with one of the surgeon's fingers in the mouth in order to protect the inside of the mouth from getting poked through by the needle. You don't want that because the inside of the mouth is dirty. And then the needle goes through and goes into this part of the trigeminal nerve where heat or balloons or whatever method of doing the procedure is chosen is deployed. These are some X-ray pictures. So the way we do this is with X-ray to guide where exactly we're going. So on X-ray, we can see the foramen ovale, which is that hole in the base of the skull, and aim the needle towards that hole in the base of the skull in order to put the tip of the needle through. And we can use all sorts of different methods. If you're awake during that procedure, we can ask, is this where your pain is, by applying a little bit of stimulation. If you're asleep, we can use some types of physiologic monitoring, which isn't always as good as having you awake, but there's a couple of newer physiologic monitoring methods that allow us to pinpoint with some accuracy where exactly we are on the nerve to ensure that we have good coverage of your pain afterwards. Rhizotomy outcomes are not as good as microvascular decompression outcomes, but not everyone can have the big surgery that comes with microvascular decompression. As I mentioned earlier, better with the frail and the elderly, or with people with a lot of medical comorbidities. It comes with about a 30 to 50% reoccurrence at 3 to 5 years, and can need repeat treatments. Repeat treatments are quite easy with this because it's just a needle that comes through the cheek to go to the bottom of the skull. But it certainly has a much shorter duration of treatment and a much less effective duration of treatment than microvascular decompression. It is still a good option, though, for a couple of different populations. The population I'll add to that is if somebody had microvascular decompression before and the second procedure didn't work for them, or they don't want to have a second procedure, or they're no longer a candidate for a second procedure, this can be a really good way to relieve the pain. Stereotactic radiosurgery is the third of that trio that I talked about at first. So this is a picture of a cyberknife, which is one of the three main ways of doing stereotactic radiosurgery. This is invented at Stanford, so where it's quite near and dear to our hearts. And this is an example of a plan for stereotactic radiosurgery of the trigeminal nerve. You can see, again, this is the MRI, T2 with the water bright, as I mentioned earlier, the brain stem here, and this black strand is the trigeminal nerve. We target a small segment of the trigeminal nerve close-ish to the brainstem, far enough away to avoid giving radiation to the brainstem because that can cause some damage, but close enough that it's close enough to the exits out of from the brainstem because our evidence says that that works better. It's an alternative to MVD for people who can't have MVD, or it's a good alternative after failure of having a more invasive treatment. And the benefit of it is that it's well tolerated for people with who are elderly or have higher operative risk or don't want to have a surgery. And it has a low incidence of facial numbness and it's repeatable. But more than all of that stuff, it's outpatient, minimally invasive. Going back to this slide, this is just a bed that you lay on. There's no cuts, there's no anesthetic. It's super minimally invasive. The risks, comes with, I mentioned earlier for MVD, it's sort of like this, but 5 to 20% risk of numbness after the initial SRS, 30% for subsequent SRS, paresthesias, which is like weird sensations in the face, 6 to 13%, and anesthesia dolorosa, which many of you guys may have heard of, which is a constant painful numbness, less than 1% with this treatment, and very, very low rates of hearing impairment or myelitis after having this procedure. As I mentioned earlier, it's outpatient, non-invasive, doesn't come with any cuts, no anesthetic, no anxiety-inducing procedures. You just come in, you wear your street clothes, you lay on the bed, and then this head of the SRS machine is where the linear accelerator is. It moves around you, and the couch moves around, and this thing plans like 100 to 130 beams that then all line up on the trigeminal nerve. There's very minimal damage from radiation to the rest of your brain, and the radiation beams all line up on that point of the trigeminal nerve and cause nerve damage, just like all the other procedures. The outcomes are pretty good. In the short term, pain-free, 65% of patients have pain-free status. There's a significant pain reduction in 80 to 95% of treated patients. And it takes about 3 months for the pain relief to kick in. Sometimes it's shorter. Yeah, it can be the next day there's pain relief. Sometimes it takes longer, but that's about the middle of the road is 3 months. And pain recurrence happens in 10 to 25% of those successfully treated over about 3 years. So sort of similar to the physical rhizotomies in overall. And just like with the physical rhizotomy, the pain control wears off over time. So at 2 years, about 60% are pain-free. At 3 years, about 60% remain pain-free. At 5 years, it's like a third of patients are pain-free and 50% have good control. At 7 years, only about 30% of patients have good control. And at 10 years, about a quarter of patients have good control. But as we mentioned earlier, it's repeatable. So when the pain control wears off, it can be redone. That's done usually with a lower dose to avoid further damage and to minimize the chance of that anesthesia dolorosa. The pain relief results are a little bit worse than with the first round of SRS. It's more like 60 to 70% of patients get pain control. And there's a little bit of a higher incidence of cranial nerve dysfunction. So things like swallowing difficulties are pretty uncommon, but can happen. Things like hearing loss are a little bit more common. Overall, this is sort of what it looks like with having a repeat MVD. As I mentioned, it works having a repeat MVD, but it lasts less long, it's a little bit less good. And it also comes at more of a risk to the other nerves and for nerve complications themselves. That's sort of exactly what we see in SRS. It works a little bit less good, it lasts a little bit less long, and it comes at more risk to the nerves. Just as a short aside, I mentioned tumors earlier. I'm not going to talk very much about this, but stereotactic radiosurgery also works to relieve pain caused by tumors pressing on the trigeminal nerve. we've seen in more recent studies. This is a study done by our group a couple of years ago. And they looked at whether radiosurgery done to tumors that are pressing on the trigeminal nerve and causing trigeminal neuralgia lead to relief of that pain. And they found that actually it has a pretty good rate of controlling the pain with just stereotactic radiosurgery. Of course, surgery can also be done to just take the tumor off the nerve, but that comes at the cost of having a surgery. So for those who are surgically averse or have high complication chances or high risk status, this can be a good way of getting away from that. Here's a short table to sort of summarize all of that. So MVD is the best treatment. Short-term relief is really high. Long-term relief is still pretty high, and it kicks in right away. The three types of physical rhizotomy are quite good in the short term. They kick in immediately, but they wear off over time. And stereotactic radiosurgery takes about 2 to 3 months to kick in. Short-term relief is also very good, and it wears off over time. And here are some references. That's the talk. I'm going to open it up to questions with it being 6 o'clock, and I can mention a couple of things about those other couple of options about surgery that are sort of less typical if you guys want, but I'll maybe leave that for the question period.
Nice.
I see that Dr. Park is on the call too. Dr. Park is an assistant professor at Stanford University. Thanks for joining us.
Thank you, Amit. It was great talk. Let's go over the questions. Can you open up and see the Q&A sector in the chat? And
yeah,
you can go ahead and read, and you can answer what you think. So
sounds good.
Mm-hmm.
Okay, so the first question is from Victoria Leskin.
Mm-hmm.
I do not have typical trigeminal neuralgia. Being diagnosed with post-traumatic trigeminal neuropathic pain, 8 months post-dental implant surgery. Do you think there's anything besides meds that can help me? I've not responded well to medications. Could a shot of Botox into the gum be of help? My doctor's suggesting this is a long shot. What about a neurostimulator? So you have kicked on. So that's the other option I was talking about, neurostimulators. Any kind of stimulator or implant that can help, any kind of nerve blocks that could work, and if so, what type of nerve blocks? Every time I've gone under the knife, I've not fared well. Okay, thanks for your question, Victoria. So this is a complicated question. So post-traumatic trigeminal neuropathic pain falls into that not trigeminal neuralgia spectrum that we were talking about. So it unfortunately doesn't respond very well to things like microvascular decompression, which is the best option. Nerve blocks that work. So you can actually have any sort of nerve block that covers the area of pain that you have, and those might work in the short term, but they're very temporary measures. Neurostimulators are actually a very good option for your particular brand of pain. So we do that at Stanford for sure. There's the neuromodulation team that does that more so. The center that I came from does a lot of that in Canada, and there's many centers in the United States that do that as well. And there's two brands of stimulators. One type of stimulator is a stimulator that goes into the area on the face where you're having the pain and applies a current every so often. That works pretty well. We see meaningful relief of pain in about 50% of patients, with the results improving over time with that type of stimulator. The other type of stimulator is very new, and there's not good data on it, but it seems to work in a lot of patients. It's called a Gisserian ganglion stimulator. It's very similar to a rhizotomy, where you have a needle put into the foraminal valley, just like that procedure I was showing, but instead of applying a shock or inflating a balloon, electrode is put into the Gisserian ganglion and connected to a pulse generator, just like a pacemaker that sits on your chest. And that applies shocks directly to the intracranial part of the trigeminal nerve, so the part inside of your head. And that works even about 75% of the time based on the literature that we have so far. But as I said, it's very new. The results aren't extremely high quality. So I hope that answers your question. It probably isn't a bad idea to pursue a stimulator, but searching through different options is a good idea. For Botox, Botox results are up and down with pain control for trigeminal neuralgia. It's better for things like hemifacial spasm and where the muscles are misbehaving. It has been used and it can lead to some temporary relief, but it would end up being sort of frequent injections if you get any relief at all.
That's good.
And then we could just read the questions without having to state the patient's name.
Oh, yeah, sorry. Question number 2, what are the risks of the brain surgery? So as I mentioned, major complication risk is probably about 5%. Minor complication risk probably comes up to about 10%. Major complications can include things like strokes, injury to the brainstem or one of the cranial nerves, very low, less than 1%. Infections inside of the brain, and looking specifically at what the different cranial nerve difficulties can be. Broadly speaking, that can be facial numbness, facial weakness, swallowing difficulty, and hearing difficulty. The one of those that happens the most often is numbness, which is usually a more minor complication, 5 to 20%. The one that happens most frequently that's more major is a hearing decrease after surgery. That can happen in up to 2 to 3% of patients following this type of surgery. Okay, third question. Are you familiar with Botox treatments for this disease? Does it work? So I alluded to this earlier. Botox treatments for this disease can work in selected cases. Most frequently, it's used in and works in more atypical trigeminal neuralgia. It can be used for typical trigeminal neuralgia as well, but as I mentioned earlier, it's more of a temporizing thing. It doesn't really have very good long-term treatment evidence, and the evidence for it in pain control is, as I mentioned earlier as well, more poor than in facial spasm. Another question, are you familiar with trigeminal tractotomy? It has been suggested to me for anesthesia dolorosa. Yeah, so there's a couple of procedures that are much less common but are done. So there's 2 major types of trigeminal tractotomy. There's trigeminal nucleotractotomy, which is a stereotact procedure, which is done to target the trigeminal tract inside of the head, often at the thalamus. It can be done as a thalamotomy, or in the midbrain is common as well. That involves putting a needle into the midbrain and then applying an electrical current to damage the trigeminal tract, so a tractotomy. And that can help with anesthesia dolorosa for sure. It can also help with refractory trigeminal neuralgia. It comes at the cost of numbness pretty much every time, but that's already sort of happened with anesthesia dolorosa, so that's a pretty minor thing to deal with. It's a much higher risk procedure than any of the procedures we're talking about as the standard procedures, though, for trigeminal neuralgia, and it requires a sort of expert hand, more of a functional stereotactic neurosurgeon. The other procedure is called nucleus caudalis lesioning. So the trigeminal nucleus in the brainstem actually comes all the way down to the spinal cord. And by doing mapping, you can find where the bottom part of the trigeminal nucleus is, which is where most of the pain originates from. And you can sort of go into that and damage it by just cutting across it with surgical instruments. Sort of the same thing. It comes at risk of facial numbness and then sometimes weakness to certain muscles of the face, more to do with chewing. But it's lower risk overall and more commonly done than a nucleotractotomy. They're both good ways to deal with anesthesia dolorosa. Neither of them works 100% of the time. Once you start getting into anesthesia dolorosa, you're dealing with sort of 50 to 70 at best % relief rates after surgery. But certainly they're both things that are done and can have some meaningful effects. Thanks for your question. I had SRS and was pain-free for 5 months, and then the pain came back. Currently taking pregabalin, the pain is coming through. What do you recommend? So, I mean, it's hard to make recommendations based on short snippets on a presentation forum like this, but certainly it sounds like you're having trouble with pain coming back, and those options that we talked through today could all be potentially options. So, as I mentioned, you can have repeat stereotactic radiosurgery. It could be that the lesion that you had at first was simply not adequate, but that does come at some increased risk of damage to cranial nerves and anesthesia dolorosa over time. You can also consider one of the other minimally invasive ways of doing this, like with the needles for rhizotomy. Or if your MRI shows a blood vessel and you didn't have it treated at first, you could reconsider microvascular decompression. But there's sort of a lot of details that point us in different directions for each individual case. So I certainly recommend talking to a neurosurgeon, and we'd be happy to see you at Stanford. If you were to send out a message to, see Dr. Chang, who's my boss and treats many patients with trigeminal neuralgia, we'd be very happy to review your case and see you. But that's about the extent, I think, of what I can give over the webinar. Another question is, how does having a destructive procedure affect a later MVD? More complications? There was a recent publication on this exact topic as well in Neurosurgery, which is our other major journal besides the Journal of Neurosurgery. And the answer seems to be that it doesn't have much of an effect. MVD still works if you had a destructive procedure and then try an MVD later. It comes with a little bit more scar tissue, so you can have a little bit of a technical more difficulty in doing the procedure, but it's not like 5 times more difficult. It tends to be like 25-30% more difficult. And it's still doable and it still has good outcomes. So no, you can still consider it MVD if you had a destructive procedure and it didn't really work for you. I have MS and was advised that MVD wasn't an option. Is that the Stanford view too? I had SRS 2 years ago and doing great. That's a really complicated question. So there was a paper published about 8 years ago that looked at MS and microvascular decompression. And the output of that paper was essentially, don't just, because the patient has MS, don't just say MVD isn't an option in every case. MS that's causing lesions in the brainstem that's causing the pain without a blood vessel, MVD isn't a good option. You're never going to get rid of the lesion without causing a lot of damage. So you're never going to cure the nerve that way. But if there's a blood vessel and there's a lesion nearby, it can be worth a shot to still peel the blood vessel off. In that series, they had actually pretty good results peeling the nerve away from structures that are compressing it, even in patients with MS. But it's a judgment call, and there's a chance that you have the big surgery and you get the Teflon put in to peel the vessel off, and you still have pain after and still need the SRS. I think that the SRS that you had is a very reasonable option. I'm really glad that you're doing great. Another question is, I have neuralgia for about 7 years on gabapentin.
I think this patient, this audience had like all questions connected all the way down through, and eventually want to see us mainly. So please help us to send our info, like Dr. Chang's info, to schedule for appointment for him. Yeah, I think we can just skip for him.
Yeah, that would be great. We would be happy to see any of you guys at any time. And also, Dr. Park, if you have input on any of these questions, please pipe up. I appreciate your experience and opinions.
You're doing great. No worries.
Thank you. For this question on gabapentin, lamotrigine, baclofen, as Dr. Park said, very limited opinions we can give with this on the web call. So yeah, best to put into us at Stanford and come see us. We'll be very happy to give you an opinion through Dr. Chang's clinic. I'm trying to find out the cause of my TN. It hit me hard in early December. Thought it was a root canal, was diagnosed with TN. However, MRI brain doesn't show tumor or artery rubbing against it. Yeah, so the important thing in this kind of a case is to really discern what the disease process is. So trigeminal neuralgia versus neuropathic pain, like we were talking about earlier. If it is trigeminal neuralgia that comes in these bursts and the MRI brain doesn't show anything, it can be a judgment call of, if you really are bothered by it, you're young, medically healthy, could try to do an exploratory surgery to look or to see if there's a vein, because veins can cause trigeminal neuralgia as well. But a safer option can be, if this truly seems like typical trigeminal neuralgia, to try stereotactic radiosurgery for this to give you sort of a minimally invasive solution that might work. What do you think, David?
Yeah, I think it's really based on the age and also the quality of the MRI. So that matters a lot. I think if you miss, because it's in a high chance you'll basically find the artery with a really good, high quality brain MRI. So even for normal people, if you do, if you just randomly pick like 100 people and do the MRI, then you'll see like a lot of this vessel neurovascular compression. So although the patients are not, although the candidates are not having any symptoms. So I think still there's a high chance that there's an artery, compressing the nerve. So first I'll ask, for a better quality MRI. And even after that, if the patient's still young, I would recommend, recommend toward microvascular decompression. Yeah. Basically, MVD, the surgical procedure is the gold standard for the management of trigeminal neuralgia. Yep.
Yeah, totally agree. Okay, next question. I have MS with no compression on MRI. I had cyberknife last year at Stanford, and now I have shocks less frequently. But now I have a dull, aching, burning pain in way more areas of my face, back of head, and eye with numbness. Is that common? What would you suggest next? To be honest with you, the distribution of the symptoms that you're having makes me somewhat suspicious that, as opposed to being trigeminal neuralgia symptoms or after cyberknife, that there might be some progressive lesions of the MS. I'm sorry to say. So, I think it'd be reasonable to get a new MRI and to book follow-up. And again, we'd be very happy to see you in Dr. Chang's clinic to sort of get to the bottom of it. Any ideas, Dr. Park?
Yeah, and just one thing to add on as a comment, for patients with MS, patients MS having like trigeminal neuralgia symptoms, eventually controlling MS is the best option. So it's the pathology is a bit different. So in many cases, when you focus a lot more on the treatment management of MS, that may wean off the symptoms. So and all of our solution as for the management of trigeminal neuralgia doesn't really work well in most cases. So, and I think for this patient, we may need a better history, since he mentioned really just simply about the burning pain, and it's a bit of like mixture of pain and symptoms. So it may not be just one disease causing all those symptoms. Yeah.
Yeah, definitely. Okay, next question. I had cyberknife in 2015, cyberknife in 2021. If I do have a recurrence of pain, do you think I would be a candidate for another stereotactic radiosurgery or a rhizotomy? I'm 81 years old. Definitely, especially stereotactic radiosurgery. I'm glad you're getting so much relief. 6 years between treatments is great. But if the pain does come back, I think, as we've discussed, you certainly, regardless of your age or comorbidity status, would be a candidate, especially for SRS, but also for rhizotomy. You agree, Dr. Park?
Yep, I agree. Yeah. And actually, there's
Next
a
one.
large, multi-institutional study ongoing on the third radiosurgery treatment for trigeminal neuralgia. So hopefully we'll get a better answer, like more with a statistical proof on that. But we've seen, like anecdotally, like we've seen many cases that work well. Yeah. Okay, next.
So I think this next one is a repeat of a previous
Oh,
question.
that one.
So, yeah, this was a patient who was pain-free after SRS for 5 months, and then the pain came back. Had a Fiesta MRI, and there is not a blood vessel or artery pushing on the nerve. Also had nerve conduction on trigeminal nerve and shows no neuropathy. So, I mean, I think at that level, you sort of have to start thinking of other options, of other things besides trigeminal neuralgia that might be the cause for the pain. So, consulting with a neurologist or getting different sequences of MRI might be reasonable. If it's decided that it's more of like a neuropathic picture, then medications might be more of an answer. What do you think, Dr. Park?
Yeah, I think this is really in a tough situation. Yeah.
Yeah, I'm sorry you're going through that.
And Yogesh is the one who asked previously, basically to contact our clinic. So I'll skip that. Age limits for MVD.
Yeah, so I mean, it really is a patient by patient basis. If you're in really good health and you have trigeminal neuralgia and you're 75 years old, you could still have an MVD. Probably it would be tough to justify doing an open procedure like that in somebody who's 80 or older, but again, it's more based on how healthy you are and how much you're willing to tolerate the risks of surgery at some level. What do you think, Dr.
Yeah, I
Clark?
think like in the past, like age 80 was always the threshold of deciding the surgery. But I think now it's going toward like really close to 90 or more, like higher. So um still it's your condition matters more than your age. Yeah. Okay.
Mhm.
What is the best procedure when my MRI doesn't show a vein touching my nerve or nerve damage?
Yeah, so we talked a little bit about that. Having no artery touching the nerve means that microvascular decompression is less likely to work. But if it is typical trigeminal neuralgia with those episodes of shocking or stabbing pain with some triggers, then having a rhizotomy or stereotactic radius surgery probably would be very reasonable options for you.
I'll just read the questions for you. Are you familiar
Sounds
with an open sensory partial rhizotomy? Is that effective?
So the nucleus caudalis lesioning thing we were talking about before is the same thing as that. That's doing a little procedure at the back of the head, opening up the dura, so the lining around the brain and the spinal cord, and then going where the nucleus is in the brainstem and the spinal cord, where they're called like nucleus caudalis in the trigeminal spinal nucleus, where the pain fibers are. So it depends on what you're treating. So medication refractory trigeminal neuralgia, for which MVD didn't work, it is pretty efficacious for that. It's a more invasive procedure, but it works 50 to 75% of the time. It's more like 50 or less percent if you're dealing with anesthesia dolorosa. That's why it's a little bit less of a common procedure. It also comes almost every time at the cost of numbness.
The next question is, I had facelift and cosmetic surgery 4 years ago. Could that be one of the costs?
It's really difficult to answer that question because sure, the trigeminal nerve branches go through that, and it is difficult to answer, partially because usually we think of trigeminal neuralgia as occurring from inside of the head, like a blood vessel impacting the nerve. And I mean, the trigeminal nerve is in the face, so you think, oh, like, you do the facial procedure, maybe you'll have an injury to the facial sensory nerves and cause that condition, but it just isn't usually what we see. Usually what we see is something inside of the head causing trigeminal neuralgia. So I think it's a difficult question to answer. I don't think anyone can say like definitely yes or definitely no, but I lean away from it. What do you think?
Yeah, me
David?
too. It's hard to say. I mean, facelift and cosmetic surgery will be like very superficial to cause like similar symptoms of trigeminal neuralgia. Like considering the track, I mean, the passing like corridor of, I mean, yeah, the track pathway of the trigeminal nerve. But I mean, sometimes like general anesthesia can be changing your body condition in some way and cause some difference, or also like since also like the big like significant difference of weight change can also cause some neurovascular compression sometimes. So I mean there's no clear proof, but you know it may be like indirectly involved, connected, but like I don't see like real direct uh, connection between those. Yeah.
Yeah, no, I completely agree.
I had my surgery at Stanford 2020 December, and I'm glad I went through that rather than take carbamazepine forever. Okay, thank you. So it seems
Very
like,
glad to hear it.
yeah. And additionally, my doctor has mentioned a trigeminal ganglion stimulator. Is this familiar to one you just mentioned? Maybe
Yeah,
this question came out, yeah, when you were talking about the stimulator, right?
yeah, this is the same as the Gisserian ganglion stimulator. It's a same procedure, like putting in the needle and then putting in the electrode. It's a good procedure. It has very good efficacy rates. Certainly, it's a good recommendation by your doctor.
Yeah, just want to say that those two, additional options are not not really typical. So either three options that Dr. Amit Persad mentioned during his talk will be the more like common and standard treatment options for trigeminal neuralgia. So if you are having if it's the first symptom that you are having and you never had like any treatment for that, then considering MVD, the surgical option or radiosurgery or rhizotomy will be more appropriate. Yeah.
Oh yeah, no, like definitely agree with what Dr. Park just said. These putting a stimulator in the face or putting a stimulator up through the skull, those are like these were come up with as last ditch kitchen sink options. Like this is everything hasn't worked. You've had multiple surgeries. Now you get this thing because they come with their own unique complications. So, you get an infection in this thing, the whole system has to come out. It costs a huge amount of money. It like makes it difficult to put a new one in again. You have to like live with a battery implanted in your chest. You have to come into the clinic to have it reprogrammed. You got to learn how to use a programmer. These are, like really fringe treatments that if you can have something else that works, it's way better.
Mhm. Judith, maybe pretty early. I had a question before, so sorry typo. My first radiosurgery was Gamma Knife, and the second was Cyber Knife. If I do have recurrence of the pain, do you think I would be a candidate for another radiosurgery or rhizotomy? I'm 81. Did we answer already? I think it was the same
Yeah,
question
I
before.
think we answered
she
that
just
one.
changed.
Yeah.
Mhm.
Yeah, definitely still a candidate.
Yep. And there's no big difference between Gamma Knife and Cyber Knife. You just need to think that both options as a radiosurgery. Yeah. Are you familiar with percutaneous bupivacaine and depomedrol rhizolysis of trigeminal ganglion under fluoroscopy procedure? I heard someone had success with this with Dr. Sekula in New York.
So, I mean, I read a paper on this procedure. I'll admit that I'm not the most familiar with it, but there's a number of variations of the rhizotomy procedure. So this is really just a variation of the rhizotomy procedure where instead of putting glycerol, you're putting bupivacaine, which is like a nerve freezing agent, and dipomedrol, which is an anti-inflammatory steroid, into the ganglion in the same exact manner. There's a lot of different investigations of different drugs that can be used to try to make the outcomes better, and this is just one of those. So I don't think many people are doing it with this particular drug, but the outcomes seem to be reasonable. So I don't think there's anything wrong with it.
Yeah. Targeting trigeminal ganglion under fluoroscope is nothing new. It is the typical way of doing percutaneous rhizotomy. And I think the only difference what Dr. Sekula in New York is doing is a different agent of chemicals that you inject through this rhizotomy procedure. So that can vary. Yeah. With classical trigeminal neuralgia, which is done more commonly at UCSF and Stanford, rhizotomy or Gamma Knife, Cyber Knife.
Yeah, I mean, David, you have more experience seeing sort of the breakdown, but I think it's about even. And I think it's hard to talk for UCSF because we don't, Stanford, UCSF, we share patients and we collaborate in some ways, but they have their own separate practice and their own like surgeons who have their own preferences. But in our like in Dr. Chang's practice, it's mostly a Cyber Knife, but there's also Dr. Lim is another surgeon who does a lot of MVD and he does a lot of rhizotomy. So to some extent, it probably depends on surgeon preference, but I think it's probably 50-50 is my guess. What do you think?
Yeah, I think we still have a bit more of Cyber Knife here, but historically, it's going to be a lot more with Cyber Knife since like 2000. Yeah, I'm trying to figure out the cause of my trigeminal neuralgia. It hit me hard in early. Did we also went through this? Yeah, I think we already went through
Yeah, I
this.
think so.
My pain runs up the left side of my face, mouth, nose, eye, and forehead. I feel like I'm having damage with memory. Is this something that happens? Is there a chance of damage with the procedures?
Yeah, I mean, we'd be happy to see you in at the Stanford clinic to sort of delve more into this. But things like nose, eye, so eye pain can be a trigeminal neuralgia, but nose and the distribution of many things that you're saying, certainly the memory isn't consistent with trigeminal neuralgia. I'd be hesitant to make any sort of comment just based on the details that you've given, but I think it's something that seeing a doctor for, and we'd be happy to be the doctor that you see, would be very reasonable.
Mhm.
What do you think, David?
Yeah, so all three options that Dr. Amit Prasad clearly explained, those are not really, there's no clear relationship with memory issue. The only thing that I can think as an indirect way is after microvascular decompression, since we go through the posterior fossa, like the back of your head, this may have, like, there's a chance that you may have like another disease called hydrocephalus, and that can cause a memory issue. But other than that, there are actually many patients who come, after any type of brain surgery and having some memory issue. And in most of the cases, we don't really have clear answer for that. Yeah. May not have like any connection with the procedure itself. Okay. Diagnosed with trigeminal neuralgia 3 years ago. Have taken all the meds prescribed that did not help. Also had CyberKnife, did not work. Had right percutaneous sternocpalatine ganglion nerve block. This made things worse, and the entire right side of my face and mouth numb and painful. What else can be done? The pain is continuous. Thank you. Wow,
Sorry to hear it.
Yeah,
Yeah.
this is very tough situation. It seems like this patient didn't go through MVD, right?
Yeah, that seems like the glaring thing that's missing is
Mhm.
if an MVD could potentially be something that helps. But as we've kind of generically said with a couple of other things, it's difficult to give specific advice on this without seeing and talking to you with the details of your chart.
Mhm. Yep. V, I think time's over at this moment. Should we end the talk?
It's up to you, Amit. If you want just to take a few more questions and then
Yeah, sure. We can go a little bit longer. Like, why don't we go until 6:35 and
yeah,
try to blast through
if
as
you
much
have
as
to
we can.
go, Amit can
Mhm.
answer if you
Yep. I personally have to leave for next
okay.
meeting at 6:30, but yeah, I mean, it was great talk, Amit, and for the
Okay.
Thank you.
audience, thank you for joining this talk today.
Yeah,
Thank you.
we'll take a couple more questions. Thank you, Dr. Park.
Yep. Bye-bye.
Thanks very much, Dr. Park.
Um,
Okay.
so,
So, and I'll reiterate what
okay.
David said earlier. V, if you don't mind, like if any of these patients want to be in touch and get redirected to see us in clinic, be very willing to. Like Dr. Chang is very open to taking referrals.
Yeah, they can also just email me directly. They should have my email since they got their confirmation from the Zoom. That's my email address. It's veevo@stanford.edu. If anyone is interested in having our team take a look at your films, or if you want to come to clinic to be evaluated.
Yeah, we're
So
very happy to see you, and we welcome any of you guys to email V, as she just said, and see us in the clinic at Stanford. If you guys are far away, if you're not nearby, we can also arrange a teaching visit, which is just like an online Zoom call where we can talk about your specific chart and we can have a chance to review your imaging. That can be a good option as well. I'm a bit lost among departments at Stanford. I had oral cancer 7 years ago and I have multiple surgeries and radiation. I developed trigeminal neuralgia after scar reduction procedure last June. My doctors haven't referred me to a trigeminal neuralgia expert. I'm finding my own way. Just started seeing orofacial pain management. Who should I really be seeing? Orofacial pain management is probably a reasonable place to start. As we discussed earlier, where there's a high chance with the type of surgery that you have, but what you really have is nerve damage and neuropathic pain. Medications are probably the best option, at least in the short term. But if that's not working, you could be a candidate for things like certainly stereotactic radiosurgery or even some of those stimulator procedures. But definitely, it's not unreasonable to see orofacial pain management and ask them about referral to see a trigeminal neuralgia expert, which would be a neurosurgeon. Dr. Chang, as we mentioned, would be happy to see in the short term or in the intermediate term. And we could even, so like by emailing V, as we talked about, we could even arrange for a teaching visit to talk more about that. TN for 2 years, then CyberKnife, which worked great for 5 years, then stopped working. Second Cyber was denied by MD because of past bad outcomes. And my TN location was too close to the brainstem. Afraid of MBD because of the interaction with the brain. Any thoughts? So, I mean, it really depends on your age and medical comorbidities. Trigeminal MBD is really, you know, I understand the fear of brain surgery is certainly daunting, but it's a really good option for treating pain if there's a vessel there. As I mentioned, it has the highest rate of success and the longest duration of treatment effect. But certainly, if you're completely against it, second round CyberKnife is an option. Please just send me a message, and then we'd be happy to see you and discuss those options. But really, if you have any sort of part of you that's open to MBD, that would be a really strong consideration, I think. Might give you better outcomes if your imaging suggests that that's a procedure that might be viable with the blood vessel touching the nerve. How can I access this recording? How can they access this recording?
The recording will be posted on our YouTube channel. I will also email those who registered for the meeting a link to our video once it's uploaded. So that should be available at the end of the week.
Perfect. Thank you. How well are you able to target the specific nerve that is causing the pain? So with an MVD, the open surgery, perfectly, we can see the nerve and we can just peel the vessel off of that nerve. With the other procedures, with the SRS, within a millimeter of precision, because we can see the nerve we're targeting on the MRI. With the rhizotomy procedures, also with high effectiveness. We're not seeing the nerve in that procedure, but we get electrical feedback, and we also, if you're awake, can ask you for feedback. Either one works very well, the electrical feedback or the asking you for feedback. So I think the answer is with a lot of effectiveness, we can target the specific nerve, no matter what the procedure is. I had radiosurgery many years. 10 years ago, pain has gone away. I take meds 3 times a day. My major issue has been numbness on my left side of my face from my eye, the bottom of my lips. Yeah, I'm sorry that you're going through that. Numbness is certainly something that can happen after radiosurgery. I'm really glad your pain has gone away. And although it sounds like you have numbness, it sounds like the pain control is good. There's not much, I don't think, that can be done about numbness itself. If that became painful numbness, like anesthesia dolorosa, that might be something that needs addressing. But it sounds like overall, I'm really happy that your pain is being controlled. Can tooth extraction impact TJ nerve on upper face area? Certainly, tooth extraction can cause pain syndromes by injuring the nerve. I don't know if, like, as we mentioned before, there's been some debate, and I don't think we can say that that's necessarily the same as trigeminal neuralgia, but certainly that can cause pain. Diagnosed with TN 20 years ago, Tegretol at 600 milligrams a day. I'm 66 years old. Is it ever too late to have MVD? At 66 years old, if your medical status is good, it's not too late to have an MVD. If you wanted to have that, then that's something we could certainly talk about. Again, send me a message if you wanted to talk with our team, or your local doctor would be perfectly good to talk to about having that done. It really depends on what your MRI looks like, of course. If you're having good control on the medication and tolerating it, and the MRI doesn't show anything, then probably it's best to continue that. But if you want off the meds and the MRI shows a blood vessel, then that might be not a bad idea to do. I have post-traumatic neuropathic pain from wisdom tooth removal, and my MRI was unremarkable, which was a vague surprise. Do you recommend a high-quality MRI or any other imaging? How can I move forward? I'm currently not a candidate for surgery, but I have not responded to any of the 12+ medications I've taken over the last 2+ years with major side effects. So I'm really sorry to hear that. That sounds really difficult. A higher quality MRI is always a good idea because it lets us see the nerve in great detail. Pain specialist for medication is probably the best way to move forward in the immediate term, but asking for a referral for pain services, for surgical pain services, if the MRI doesn't show anything to target with an MVD, you could still be, depending on the rest of your story, a candidate for either SRS or one of the stimulator options. But again, it's really difficult to say without seeing you and reviewing your whole chart. So please be in touch with me if you were interested in seeing us. Otherwise, probably best to talk to a neurosurgeon who's an expert in multimodality pain treatment. I had SRS about a year ago at UCSF, and I'm blessedly pain-free. Thank you. I did have almost constant headache, low energy, and slight dizziness for several months after the procedure. There were no confounding variables such as other illness or medication change. Is this unusual? No, I would say that some headache, probably from swelling, low energy, and slight dizziness wouldn't be terribly unusual after the procedure. For it to last several months is unusual, but I'm glad you're doing great now. It's sort of one of those circumstances. If anything that can happen, it probably is related to the SRS because you did have that done. Usually that doesn't happen. Usually people go home and they do great. But it sounds like things are going well now, so I'm glad to hear that. What would you recommend to a patient with MVD that failed and left me with anesthesia dolorosa? That's a really complicated question that you'd be best served addressing in the clinic. So again, we'd be happy to see you, but the options for anesthesia dolorosa are more complicated and involve things like neurostimulators or potentially trigeminal nerve lesioning, like we talked about before, like along the tract, brainstem lesioning and that sort of thing. But again, it's difficult to make a recommendation like that without talking in detail and being able to review your chart and imaging. You are welcome for answering your questions. Is a rhizotomy the same as what is called a nerve block? No, a nerve block is temporary, much more temporary. It usually is just from injecting a medication. Rhizotomy is actually lesioning a nerve and causing some damage with either heat, chemicals, or mechanical pressure. Okay, I think that's probably good for an LV. Thanks very much.
Okay, so thank you for everyone who joined our meeting tonight. If you have any other questions, you can feel free to shoot me an email. Thank you, Dr. Persad.
Thanks for having me, and thanks all of you guys for attending.
Have a good night.